So also in the general statements of the guidelines and the cardiac societies, we distinguish coronary spasm from impaired vasodilatation, and we can test both of these during our catheter sessions. And maybe you can tell us a little bit, you have more experience with the invasive testing.
Yeah.
How would you test these functional disorders in the cath lab?
Yeah, thank you for this question. I think it's very important, especially for interventional cardiologists, to understand that these additional assessments can be done in the cath lab with no additional costs and with only very little additional time. Hello, everyone. Thank you very much for joining us for this ECR podcast today. My name is Peter Ong. I'm a cardiologist from Stuttgart in Germany, and I'm joined here by Andreas Seitz, my co-host today, who's working at the same institution. The topic today is invasive diagnosis of coronary functional disorders causing angina pectoris, and we are very happy to have you here today to discuss this interesting topic. So, Andreas, my first question would be just the clinical scenario. You have a patient with chest pain, and the patient is sent to you for diagnostic coronary angiography, and then it turns out that the patient has no epicardial stenosis. So what do you do, and how do you handle these patients usually?
Yeah, that's a very important question because that's a clinical situation or a constellation that we see pretty often in daily clinical practice. And I guess that most cardiologists who listen to that podcast also see this in daily clinical practice. And actually, we know from large studies from the last couple of years that almost or about 50% of patients undergoing invasive coronary angiography for suspected obstructive disease turn out to have non-obstructive coronary arteries. And so we don't really have an explanation for their symptoms at this point. And we also get more data and information about coronary functional disorders, which are disorders that cause angina in the absence of coronary artery disease. And in such patients that we see in the cath lab, it is important to also look beyond stenosis and to look also for coronary functional disorders, which we can easily assess during coronary angiography.
Yeah, thank you for this explanation. What is actually coronary functional disorder? One problem that I have is that there are lots of different terms used for this kind of coronary disease. So what can you tell us about the terminology and also about the different types of functional disorders that are most relevant in patients with angina and unobstructed coronary arteries?
Yeah, that's true. There's some inconsistency regarding terminology for these diseases. Some call it coronary functional disorders or vasomotor disorders. Those are the two major terms that are used to describe them. And coronary functional disorders in itself is an umbrella term for a whole group of functional disorders of vasomotor function, of vasodilatation or vasoconstriction, let's say of the autoregulation of coronary vasomotor. And what we have on the one side is we have impaired vasodilatation. Vasodilatation, especially of the coronary microvessels, is extremely important to adjust coronary flow and oxygen supply to oxygen demand, depending on the situation and physical activity of the patient. So it's important that coronary vessels are able to dilate and increase coronary flow. On the other hand, we have situations where we don't need so much coronary flow, so much oxygen, and then coronary vessels can constrict. And so we have two main mechanisms. The one is vasodilatation, the other is vasoconstriction. And in the healthy heart, we have a good balance of the both mechanisms. But there's some disease states where we have imbalance and we have increased vasoconstriction, especially, or impaired vasodilatation. And those are the two main disorders that we can have. We can have patients who tend to have increased vasoconstrictive tendency, and which leads to coronary spasm. And we have patients who cannot dilate their coronary microvessels adequately, and they may have issues adjusting their coronary flow to the oxygen demand during physical activity. So also in the general statements of the guidelines and the cardiac societies, we distinguish coronary spasm from impaired vasodilatation, and we can test both of these during our catheter sessions. And maybe you can tell us a little bit, you have more experience with the invasive testing.
Yeah.
How would you test these functional disorders in the cath lab?
Yeah, thank you for this question. I think it's very important, especially for interventional cardiologists, to understand that these additional assessments can be done in the cath lab with no additional costs and with only very little additional time. So the diagnostic benefit that you get from performing these additional assessments is very high. It has several advantages when doing these invasive tests, because once you find the diagnosis and the explanation for the patient's symptoms, you can not only give the patient the right treatment, but you can also reassure the patient that a cause for the symptoms has been found and that this can now be adequately treated. Another important aspect is that you can also estimate the prognosis of the patient from the results of the additional assessments. And in some of these patients, a more close follow-up is necessary. What is also important is that these additional invasive assessments can be done immediately after diagnostic coronary angiography. You can prepare the additional assessments upfront if you have a high suspicion that the patient has no epicardial stenosis. And it is also important to acknowledge that acetylcholine and adenosine are the two provocative substances that should be used when performing these assessments. And there's, of course, a large variety of how to perform these assessments. But the main thing is that acetylcholine is used for assessment of coronary spasm, and adenosine is used for the assessment of microvascular vasodilatation. And I think that's important to know, that these two substances are used, and the rest is then discussed in more detail a bit later.
Okay, great. So what would you do in clinical practice if you imagine you have a patient on the cath lab, you just did your diagnostic angiography, which didn't show any obstructive disease? How would you start? Would you start with the adenosine provocation or the acetylcholine? What's your standard?
Yeah, thanks for the question. I think it's very important that we talk about two different scenarios. One scenario could be that the patient has some form of epicardial disease, and you would perhaps like to know what is the measurement of a pressure wire, just to exclude a hemodynamically relevant stenosis. So in these instances, I would always prefer to perform the adenosine test first, because it not only gives you the information about the relevance of the epicardial plaque, but also additional information about the function of the microcirculation. So the systems that are available at the moment can not only tell us what's the FFR, but also tell us what is the coronary flow reserve and the microvascular resistance. And then just if the patient has no relevant epicardial disease, then these measurements can be done, and they are indicative of microvascular function, and afterwards acetylcholine testing can be performed to inform us about the coronary spasm tendency. In patients where there is absolutely no epicardial disease and you would not start with the pressure wire because of epicardial plaque, I would always go for acetylcholine first, because studies have shown that the frequency of abnormal acetylcholine tests in these patients is very high. So I would not need to place a wire. It's done in a very short amount of time, and the diagnostic information is very high. So that would be then my favorite. And only if acetylcholine testing shows no coronary spasm, or if I want to have the full picture of information, then I would go for adenosine testing with the wire in the artery after acetylcholine. And of course, it's also important to think about the prevalence and the frequency of these disorders, as I just said, because it may also trigger the sequence of testing. Andreas, can you tell us a bit about how the frequency among these different so-called endotypes is distributed? So how many patients have coronary spasm if they are examined by this complete protocol, and how many patients have impaired vasodilatation, and what is the frequency of the mixed results that you can also have?
Yeah, that's a very good question. And during the last couple of years, we've been getting a lot of information and scientific data on these prevalences of the different endotypes that we were just talking about. Because a couple of years ago, in the last decades, there were several groups in the research area in this field which rather focused on one of the two mechanisms, and some groups rather focused on coronary spasm and not impaired vasodilatation, and others did the way around. So it was always kind of a missing whole picture, because comprehensive testing, which did include both mechanisms, has not been done in a lot of patients until a couple of years ago. And now there's increasing evidence from studies where both mechanisms were tested in the same session, the same patients. And we now learn that coronary spasm is by far the more prevalent disease in patients with angina and non-obstructed coronary artery disease. There's some data from the Netherlands and also from Japan that show that about 80–90% of patients with ANOCA or INOCA have coronary spasm, either of the coronary microvasculature or epicardial coronary arteries. And some of them may also have impaired vasodilatation of the coronary microvessels in response to adenosine. But this is rather the smaller number of patients. And then there are only a very few patients who only have impaired vasodilatation without enhanced vasoconstriction, without coronary spasm during provocative testing. And this is what you just said, that you go for acetylcholine first whenever possible or whenever reasonable, because we know that there's such a high prevalence of coronary spasm in these patients, so that it's the most easy and fastest way to get to the diagnosis. And we also need to consider that there are still some challenges with endotypes, because we all know that the coronary flow reserve, which you were just talking about, is the index of hyperemic coronary flow and resting coronary flow. And we know that this index is highly dependent on resting coronary flow, of course. And we don't really know which impact resting coronary flow has. And so during the last couple of years, the microvascular resistance measurements, which is HMR for hyperemic microvascular resistance, or IMR for index of microvascular resistance, have been gaining more and more attention, because in these measurements, they don't depend on resting coronary flow. And so they're considered to be more specific for hyperemic vasodilatation.
Can you tell us a little bit about the differences between these two ways of measuring microvascular resistance? Because it's probably important to talk about the two different ways of measuring it, and also about the two different systems, because the results are perhaps not 100% comparable.
Yeah, that's correct. So we have two main differences, or one main difference in measuring those indices of microvascular resistance. The first, HMR, is measured by Doppler technique. So we have a intracoronary guide wire equipped with a Doppler sensor on the tip, an additional pressure sensor, and we directly measure coronary flow velocity in the coronary artery. And using the coronary flow velocity and the intracoronary pressure, we can measure the resistance. The other technique is an indirect measurement using thermodilution technique. And in this case, we have thermodilution guide wire with a thermistor, and we inject room temperature saline, and then we measure the transit time the saline needs to get to the tip of the wire, and then we can calculate coronary flow velocity from the transit time. So this is rather an indirect measurement of coronary flow. And again, we measure distal coronary pressure as well, and then we can calculate the index of microvascular resistance. And there are several groups and using the one or the other technique, and both techniques have their advantages and disadvantages. And we also have information or first data that not in all patients both measurements agree. So there's a tendency to higher CFR values with the thermodilution technique, for example, and we still don't really know what is the optimal cutoff value for which technique. Do we need to make a difference? Current guidelines do not address this difference in techniques yet, but there's more data to come, and we'll soon know if we need to make a difference and maybe which technique is more precise or more reproducible. So this is about the endotypes and the measurements, but maybe an important question which we all, I guess, who are active in this field often hear is, what's the consequence? Why would you do such measurements and complex calculations? What's the consequence for the clinical treatment? Is there a consequence?
Yeah, I think that's very important to talk about it. I often get this question from my patients, and they're asking me, do I really need to undergo the complete invasive assessment? And then I tell these patients, look, you can also go for a trial of treatment. You can just try a certain drug that perhaps relieves coronary spasm or improves microvascular function. And if it helps in alleviating the symptoms, then one can make a decision just to continue with these drugs and not go for a sophisticated analysis with invasive measurements. But in patients where this trial of treatment is not working, and also in patients who suffer from refractory symptoms over a longer period of time, there it is very important to determine the underlying pathophysiology to go for these invasive functional assessments, because the underlying mechanism may be indicative for the correct treatment. We know that the CORE-MICA study from 2019 has shown that the diagnostic approach with this invasive diagnostic procedure, where acetylcholine and adenosine testing is performed, and then treatment is initiated based on the results of these two investigations, that this approach leads to an improved quality of life after 6 months and after 12 months. So, of course, one can argue that there is no difference in hard endpoints, but from my perspective, it's already very important that we have an approach that can lead to improved quality of life, because that is often also impacting on the workforce of the patients and also on other important factors during daily life. So the question is, what is then the appropriate treatment for the respective endotype? And of course, a lot of colleagues know that calcium channel blockers and short-acting nitrates are the mainstay of treatment in patients with coronary spasm. But there is also a proportion of patients where this, let's say, first-line treatment is not working, and then perhaps you need to go to a different calcium channel blocker, or sometimes it's also advisable to compare the effectiveness of different calcium channel blockers, and perhaps to combine two different calcium channel blockers to have synergistic effects on the vasomotion of the respective patient. So, and one can go there into quite many details if patients do not respond to the treatment, and many colleagues would go very high with the dose of the calcium channel blocker, especially for diltiazem, for example. And also the treatment of the other endotypes is not 100% clear. Of course, it would make sense to treat the risk factors, and if you have a patient with diabetes where the microcirculation is already impaired, then it would make sense to give drugs that improve the microcirculation. But another important concept is also to administer beta blockers so that a heart rate is going down and myocardial perfusion in diastole is then improved, and this can often lead to an improvement of symptoms. And of course, we know that the CORE-MICA study was just the start of prospective studies in a randomized fashion. So other studies are on the way, and they will in the future inform us about the effectiveness of different approaches. For example, the Examine CAD study will compare bisoprolol with diltiazem and placebo in a randomized fashion in patients with angina and unobstructed arteries who underwent the aforementioned approach with acetylcholine and adenosine. And we will get a lot of information from this trial regarding the effectiveness of certain drugs in certain endotypes. And the same holds true for the Ilias-Anoka study from the Netherlands with a similar approach like the CORE-MICA trial. But in this study, the Doppler technique will be used for the invasive measurements of coronary flow reserve and microvascular resistance. So I think it's an important field of invasive cardiology, and I also hope that we can encourage interventional cardiologists to add these assessments to their portfolio. Andreas, what is your opinion on the time frame that you need for the additional assessments? What would you tell somebody who's concerned about the time that you invest for these patients in the cath lab? What's your opinion?
So we calculate about 30 to 40 minutes per angio and reactivity testing. You'd probably need about 15 to 20 minutes for the spasm provocation testing and about 10 minutes for assessment of the microvascular vasodilatation. And then you should be done within about half an hour, which is not much time considering that other interventions will take a couple of hours of time, or just routine IFR, FFR measurements also take a couple of minutes. And so we just heard about the clinical consequences and the prevalence of these diseases. And I think it's worth investing these minutes and 20, 30 minutes to make the diagnosis and to treat the patient in the right fashion.
Yeah, I think it's also important that a lot of these patients come back as a so-called frequent flyer, right? They are then perhaps discharged because there is no epicardial stenosis, and then they are sent home. And after a while, they come back with unstable symptoms. So again, they undergo invasive angiography, and again, there is no epicardial stenosis. So these patients may also benefit from future presentations where perhaps no additional invasive diagnostics are performed, because it is already known that there is a functional disorder as the cause for the patient's symptoms.
Maybe one last question for you. What do the guidelines say to the testing? Is that something that is recommended, or is it something just for special centers?
Yeah, that's a good question. I mean, we are working in Germany, so the European Society of Cardiology guidelines, they are important for us. And the last guideline on the management of the chronic coronary syndrome clearly stated that these assessments are recommended. It is important to look at two different patient cohorts. The first cohort are patients where coronary spasm is suspected, especially in patients with resting angina. And in these patients, it is recommended to perform coronary spasm testing using, for example, acetylcholine with the class 2A recommendation. And then there's the cohort of patients in whom microvascular dysfunction is suspected. And this cohort of patients has also a class 2A recommendation when looking at the invasive assessments for coronary flow reserve and for microvascular resistance. So in combination, in daily practice, it's hard to differentiate between these two cohorts. A lot of patients with exertional shortness of breath, they also have resting angina. So then the question is, what is your suspicion in these two mentioned categories? And that is why I would say we have a class 2 recommendation for both acetylcholine and the adenosine testing, and that's why we should go for it in everyday practice. We hope that the future studies currently enrolling patients will contribute to a change in the guideline recommendation in the near future. We hope that we will become an upgrade from class 2A to class 1 because of the outcome data that are currently being enrolled. But that is, of course, not sure, but it would be a great step forward for these patients, because then a class 1 recommendation would come more into the minds of the general cardiologist and also of a broader community performing invasive angiography. And this would surely help the large number of patients who today go undiagnosed and untreated.
Great. Well, then I think we covered the most important topics. There's still a long way to go to introduce this to daily clinical practice in all centers or in many centers. And we'll continue working on gathering the data, and we're excited looking at the studies that are currently performed. And thank you.
Perhaps one last comment. If some of the audience would like to perform these kind of tests in their own center, we're always willing to support you. We're always willing to share our protocols and our experience. So please do not hesitate to contact us if you would like to start with these tests in your center. And finally, I would like to thank you for listening to this ECR podcast. Thank you, Andreas, for sharing your thoughts with us. And thank you very much for participating. We would hope that you continue listening to the ECR podcast in the next issues to come. And thanks very much, and have a good day. Bye-bye. Thank you.
Bye-bye.